Hello, I'm Dr. Maria Sulindro, integrative anti-aging medicine practicing in Pasadena, California. Today, we have our returning guest, Dr. Darryll Sulindro. Before we start, I have to make a little disclaimer because the last time he appeared, everyone was asking if he's my son. Well, I wish he would. He's my son. He's my nephew. We have the same last name, so we call him Dr. Darryll, so it's easier, right? Hello, Dr. Darryll.
Hi, Dr. Maria. Thanks again for having me on your YouTube.
Oh, yes. Always. I'm looking forward to listen to what you have to say. So today, I would like to welcome you to subscribe, like this video, and also share with your friends. Today we are going to talk about headache and is it dangerous? Before we start that, I would like to introduce so we know who Dr. Darryll is. He's specializing in physical medicine and rehab. We happen to have the same background, but he furthered his training in interventional pain management at University of California in Irvine, California. That's after he finished his program, PMNR program at Mount Sinai in New York. So he came back to his hometown here, the beautiful city of California. Currently, he is doing his private practice at BioHealth Pain Management in Lawndale, Los Angeles, focusing in regenerative medicine, neuromodulation, and minimally invasive spine interventions. So that's basically to avoid a big surgery if not necessary. So thank you again. And when I would like to describe headache, is a very common symptoms and even used in conversation and as a jargon in daily life when people talk about problems, not knowing that for those who really has experienced it, it can be debilitating. Since it is very common, let's hear from Dr. Darryll. Can you describe what actually caused the headache?
Thank you, Dr. Maria, again for the kind introduction. Yeah, headaches are something that, as an interventional or even a regular pain management physician, we often have to deal with because we have a lot of patients in our country who are suffering from headaches. It's a very common cause of complaint. It causes a lot of, patients have to have a lot of disability, loss of quality of life, and loss of kind of productivity in our country. But when you describe a headache, it's a very broad term, right? It describes just kind of pain in the head. So I think what causes a headache, you want to classify, is it a primary cause? There are some primary headaches, meaning these syndromes cause pain of the head and face. So we have examples like a migraine headache, a tension headache, a cluster headache, or trigeminal neuralgia or pain of the nerves of the face. Those are what we call primary headache, meaning that the headache is caused by specifically by this disorder. But we also have things called secondary headaches or headaches caused by other conditions. And these are things like high blood pressure, maybe there is a tumor or mass in your brain, maybe there are other metabolic imbalances that cause these kind of headaches. So really you want to differentiate, do you have a primary headache or a secondary headache?
Yes, it is very broad. In fact, if I invite others physician specialty in a different specialty than ours, probably they also have headache informations. So since headache comes in variety of forms, also I heard or we know the story is different from one headache to another who suffer from it. When should I be worried about my headache?
Yeah, so headache or pain of the head alone, is a very common symptom, but there are other things that you want to be careful of when you have other secondary symptoms. If you would like, I have a slide of an acronym I would like to share, if that's okay with
Oh,
everyone.
please.
That, yeah, so here we have, it's a secondary headache. So when you want to be nervous about, is the headache caused by something else? So there's a nice acronym that we use, or it's easy way for me to remember. It's called SNOOP. If your headache has SNOOP. So basically, what does SNOOP stand for? SNOOP stands for systemic symptoms, meaning that other body parts have issues. So maybe you have a uncontrolled blood pressure of 200 over 100. That can cause a really bad headache. That can be dangerous to cause like a big hemorrhagic stroke or something like that. You can have a neurologic symptom. That means is you may have like weakness or numbness or tingling of one arm or one side of your body. That can be caused by a stroke, which can have headaches. That can be caused by a brain tumor, which can cause these symptoms. If the headache is sudden or new, so many people, they develop headaches. A lot of patients who suffer from something like migraines, they have had migraines almost all their adult life. Often it develops during puberty or gets worse during puberty. And these patients, for them, a headache is nothing new. But if you've never really had headaches all your life, and all of a sudden you have a headache that limits you from doing any other activities, that's something that you want to worry about. Any other associated conditions? Are you losing weight? Are you not sleeping well? Are you, not eating well? Do you have a poor appetite? Those are something that you want to be concerned about. And also, if you have any previous headache history with progression or change in the symptoms. So that kind of is very important for us to kind of see, SNOOP acronym to make sure it's not anything dangerous.
Oh, yes, of course. Also when you are at a different age and stage of life, when you are premenopause or hormone imbalance or menopause, then you can have a headache as well. Yeah, that is a very good SNOOP. Now I remember. I never had that luxury to remember it that way. So for those who do not have a headache, we don't want to experience headache. How can we prevent the headache or the recurrent of the headache for those who already have it?
Yeah, so usually the most, if you just have a pure headache disorder, meaning that you don't have a tumor, you don't have a brain hypertension or aneurysm or a vessel mass or anything like that. If it's really just headaches, most likely what you're suffering from are migraine headaches. So migraine headaches, they're about 90% of the most, they're one of the most common types of migraines. There's other types of headaches as well, like a tension headache or a stress headache from holding a lot of tension in your muscles. That's actually the most common. But the ones I see the most are migraines, because it's a syndrome and it's difficult for patients to, kind of control those. So kind of like what you want to do with these things are to avoid certain triggers and certain things that may cause these headaches. So some of the things that you can see are things like if you have kind of dehydration, if you're dehydrated, it can trigger these headaches. If you carry a lot of stress in your tension in your muscles, in your cervical paraspinals, these can cause tension headaches. If you're in a bad position, now a lot of us, me included, we do a lot of desk work. We're at the computer, we're always kind of typing away. If you have poor posture, that can lead to a lot of postural headaches as well. So I think kind of knowing what your triggers are is very important to see how to prevent these headaches. I do have another slide I'm going to share with you that
Yes.
can kind of tell us some things that are other triggers, not just positional. So these are just for migraines, right? But they can also be for other headaches. So certain medications can predispose to headaches. So patients who are on certain blood pressure medications, if your blood pressure drops too low or too high, that can cause headaches. Some, antidepressants, those can cause headaches as well. If you ever had a history of head trauma in the past. Now, head trauma is really interesting. Most of us, whether we want to believe it or not, have had some of head trauma in the past. So anytime you fell off your bicycle, fell off your bed, had, ran and bumped your head into a wall, that's considered a concussion. And now in the dogma of brain injury, that's considered a mild brain injury. So all of us may have had some head trauma in the past. Lack of exercise can predispose to headaches. Sleep changes. Me personally, I know that if I don't sleep the appropriate amount, I will have the tendency to develop headaches in the coming day. Stress, as we all know, can cause headaches whenever we're most stressed out. And certain odors and certain foods like cigarette smoking, red wine, certain cheeses, things that are high in purines, that can cause headaches. And interestingly, patients, with irregular schedule, so night shift workers, medical residents, doctors who work overnight shifts in the hospital with these irregular schedules, that can definitely cause a lot of headaches as well.
Yes, talking about schedule and shift for our doctors, the head trauma is like when we carry our medical books, right? Too heavy. That cause head trauma. What can be the cause of this headache besides, we know about epigenetics, right? Epigenetic is beyond the gene, anything else but not the gene problems. And we often heard about this epigenetic can cause other than the gene can cause this headache. So can you explain a little bit about this? You just mentioned it actually, but that's involved other than like whatever you mentioned, including other things. Do you still have other things?
Yeah, I did mention a little bit about what can cause headaches, such as the lack of exercise, certain diets, certain foods. Other common things that can cause headaches, are really, you want to figure out what your triggers are. Some people, when they get too hot or too cold, those are triggers for a potential headache. Some people are allergic to certain foods that may not be a full allergy, but maybe a slight allergy, and that can predispose them to have headaches. Patients oftentimes do much better with a diet that's low in inflammatory compounds. So lower in simple sugars, lower in processed foods. So a lot of these inflammatory compounds can cause an increase of inflammation and can cause headaches in us. Other things are environmental concerns. The incidence of things like medical diseases like asthma and cancers are actually much higher in industrial zones. So areas where there is a lot of industry in the area, a lot of toxins, that they've shown to have an increase in these chronic conditions. And they have also an increase in the incidence of migraines in this area, which is very interesting. A lot of these industries in the South, where it's close to a lot of pig farming that releases a lot of toxic chemicals in the air, they have higher incidence of chronic diseases, including headaches. So really kind of the environment where you're in can shape if you have headaches or not. I know I wasn't really supposed to touch base on epigenetics a little bit, but that's a really strong predictor of whether you're going to have a headache syndrome, be it a migraine or a cluster headache, is if you, a first degree relative, so like a parent has a history of migraine syndrome, migraine disease, there is a higher chance that the child may have it. And I think something that you can't—
that's the gene, genetics.
That is genetics, yes. And other things that you can't change is oftentimes women, unfortunately, have a higher incidence of these type of headache disorders.
Yes, thank you so much. So after we know the characteristic of that headaches and what kind of treatments and medication we should expect for the headaches?
Yes, so really the way you treat a headache is really the most important thing is prevention, right? You find out your triggers, you do your allergy testing panel, you do your foods, and you know what kind of triggers your headaches or the activities, and you want to really avoid those. But sometimes, even though the prevention measures are all there, patients still have a lot of headaches, and you really want to try to see what kind of headache is causing it, right? So if you have a tension headache, you may benefit from maybe a tension release or massage or some occupational or physical therapy to help decrease that area, to help, you may benefit from some trigger point injections in the paraspinal muscles and the trapezius to kind of release that tension headache. If you have, for example, a cluster headache, which is a kind of headache syndrome that's more isolated right behind the eye, you may benefit from some prescription medications or some high dose oxygen therapy. And the most common headache that I treat is migraines, is the migraines that don't respond well to kind of this preventative kind of behavioral therapy. We have to start often start treating with pharmaceutical medications. So the mainstay of migraine treatment for pharmaceuticals is the use of some low-dose antidepressants. They use some membrane stabilizers like topiramate or gabapentin. We may use some anti-inflammatory medications like Aleve or Advil. We'll use some Tylenol, which will help. But these are all to kind of reduce the prevention of these migraine headaches. There are other classes, of course, of medications that are not for the prevention of it, but really it's when the headache comes on to decrease the severity of how severe these headaches are. So there is a class of medications called triptans. Patients may have had it before, sumatriptan, Maxalt. These are medications which act on the serotonergic receptors in our brain, which helps decrease the inflammation and reduce the release of inflammatory compounds like CGRP and substance P, because the working theory for why patients get migraines are there is a trigeminal complex in your head, and when it's irritated and there's inflammation in the area, it releases a bunch of inflammatory compounds, and that's what causes the headaches. So some of these medications can block that.
Oh, thank you so much. So all those names that he mentioned, it's the name of the nerves that will trigger the headaches. Now, when people have frequent headaches and you give medication once, twice, and they know they use it on and off, even though they don't see you, but then one day they come again, and then you diagnose them after the CT scan, MRI, that they have brain tumor or perhaps suspected cancer. This is a diagnosis that causes another headache, a different headache, because they have an anxiety, they cannot sleep. How about knowing more so that they can sleep, because not all of them are a deadly disease? Can you describe a little bit more on this?
Yeah, that's probably, that and maybe like a stroke or aneurysm, which is a large blood vessel that grows in your head. Those are probably the worst things that a patient would want to hear, right? For something that they just have, which is headaches. Now, usually a brain tumor, headaches may be a presenting cause, but usually the patient feels something else other than the headache. They usually feel like they have a little bit of weakness, or they have some pain, or they notice some weight loss, or they notice just maybe like they're not talking or moving their limbs as usual. So, most patients with just a headache disorder really should not really be worried at all about having a brain tumor or mass. And nowadays, with these malignancies of the brain, depending on what type of cancer they are, a lot of them are treatable with a lot of they have chemoradiation, they have targeted chemotherapy, they have targeted radiation therapy, and now the neurosurgical procedures are now very advanced that they may be able to help this. But most importantly, when you have this diagnosis, I think it's important to establish care with two different types of physicians. The most important is to establish care with an oncologist or a cancer physician, preferably someone who's specialized in neuro-oncology or oncology of the nervous system. And I think it's important to establish care with a neurosurgeon, preferably someone who's a brain surgeon who has experience as well in kind of an oncological surgery of the brain.
Yes, thank you so much. Now, there is a question here that I may not know the answer, but you do. As a parents, they might know what headaches feels like in their children, because they sometimes either more cranky or they're just quiet listening to their headache. The parents worried about their children who do not know what it is. And so is headache common in children?
Yeah, headache is actually relatively common in children. Now, what type of headache is not really well known, which one is the most common, but a lot of times children may have headaches based on kind of stresses in school, social stresses, psychological stresses, but migraine headaches are relatively, I wouldn't say common, but they do happen in children. And actually where I trained in UC Irvine, we UC Irvine was one of the first kind of institutions that piloted a study to show that children with diagnosed migraine headaches may benefit from Botox injection therapy. Now, I know for those parents out there that are kind of like worried about how do I evaluate my child in terms of having headaches, I have a slide to showcase how, as physicians, when we see pediatrics, how we can kind of quantify the progress of kind of like the headache treatments and stuff like that. So let me share my screen again. So, this is mildest, which is a car company, but this is just what it's called. It's a functional assessment, the mildest functional assessment. So, when we see a child with headaches, oftentimes this is what we use. And the number of days in the last 3 months, I usually just use 1 month, because in the past when I did see pediatrics, I don't anymore, but in the past when I did see pediatrics, we would see them about once a month. But basically, what have they been doing? Have they been missing school or missing work because they say their headaches are too painful? Have they been getting worse grades? A lot of our kids, they were an A+ student, and all of a sudden they dropped to a C or B-, and then you're wondering what's going on. And often you can't concentrate when you have these kind of headache disorders. Are they not doing their chores because they're either too sluggish or too painful? Are they not productive at home? Are they not joining social or leisure activities? So you can kind of quantify over time how many of these are they missing, and what are they improving with your headache therapy or not? And I know I touched a little bit about the Botox therapy for headaches, and that's something that I personally do that has been shown to be effective in reducing the severity of my patients with migraines, as well as kind of like how often these migraines happen. And I'd like to show like a picture of how many, people think it's just a little bit of Botox. It's, people go through a lot to get these Botox injections. So this is the slide that Botox provides online. And you can see how many injections. Each dot is a single injection of 5 units of Botox. So it's about like 37 injections in the face, in the back of the head, in the neck, on the side of the head. So, patients who get this procedure have improved less headaches and reduced kind of severity of the headaches. But at the same time, it's really not a fun procedure for them to get at all.
Wow. That is a very important slides to see, actually. Yes. Maybe some of this question we have to answer it first, and let me see how to go back here. Let me see. Frequent headaches now. How do I go back? Okay, here. I know this has something to do with alcohol headache. Okay, because it's a. Can you discuss CTE in athletes with respect to symptoms and diagnosis? This is the chronic toxic encephalopathy headache.
Right. The chronic traumatic chronic traumatic encephalopathy.
Oh, yes.
Yeah. So this is a condition that we see now in a lot of our older athletes, and it's made most famous by by boxers, right? Yes. Boxers, fighters, and stuff like that. But we don't, you forget that most sports have a lot of head strike impact injuries. I think the most common head injuries for women or young girls in our nation is soccer, because it's probably the most popular sport for women in our country, and most of the mild to moderate brain injuries come from soccer injuries. So chronic traumatic encephalopathy is really means it's a repetitive brain injury, right? So I used to be a competitive figure skater back in the day before I started medicine.
World class.
Yeah, so that's what I used to do. And, I remember when I was training, the dogma was, no pain, no gain. You want to push your body, whatever effort you put in, that's what you get out. So, if any of you have skated before, you've fallen, you've hit your head and all that kind of stuff. And I remember, you would hit your head, you would take a little bit of a break, but then you felt okay and you would go back on the field, go back on the ice and keep skating. And nowadays, now as we know more research in types of these like mild but consistent and chronic brain injuries, we do know that's actually the wrong way to go about. So now the guidelines are, if you do get a head strike or a concussion, and the medical professional on the field or whoever's on the field, they usually do a testing score with certain things. Do you remember the date? Do you remember where you are? Do you remember what the score is? Do you know who you're playing? And if they diagnose you with a mild concussion injury, you're not supposed to go back on the field, because if you get another concussion injury within that same day, the risk for you to develop a severe brain injury and potentially death, it's been documented multiple times, it's like sudden death syndrome, is very, very high. And there comes to a point when you do get these repetitive head injuries where you kind of have to decide what the balance is between being an athlete and enjoying your sport as much as you can versus like the long-term risks and complications.
Do you think these kind of patients will benefit a lot from the regenerative medicine, like the exosome stem cells?
Yeah, I'm not really the expert of those kind of regenerative exosome or stem cell IV treatments especially for chronic traumatic encephalopathy. The regenerative medicine that I deal with is mostly musculoskeletal nature, meaning like the tendinopathies and the rotator cuff syndrome, shoulder pains, and like tennis elbow, golfer's elbow. So I'm sure there is a lot of data going out there. The better we're able to control like the neuroinflammation in the brain, the less chance that you're going to develop kind of the early onset dementia, loss of motor control, forgetfulness related to this encephalopathy.
Yes. Yes, Dr. Cynthia, thank you for that excellent questions, but that's our field, we know that. So Dr. Darryll, one more question if you don't mind, before I will pinpoint in your specialty on this topic here. There's another one. Victor is asking, is acupuncture effective in treatment migraine headaches? Now I know I want you to answer it first, because I know the answer. Go ahead.
Yeah, I personally have not looked into, I'm a conventional, evidence-based like Western medicine physician. So I have not really looked into what are the randomized controlled blinded studies are for acupuncture and headache, but I would like to share some of my training. I trained at the Bronx VA as part of Mount Sinai, and at the Veterans Association, we used a lot of acupuncture, and it has been shown to be effective in at least my subjective clinical experience for a lot of the veterans in PTSD and headaches, patients with kind of like different pain disorders, hyperactivity of the nervous system. So I do believe in trying out acupuncture. I just personally don't know what the evidence-based data is out there.
Yes. Mm-hmm. And my experience, if anything to do with pain, acupuncture, since, I was trained in acupuncture and herbology, there are some points that you can actually manually palpate and finger pointed and treat yourself for migraine and headaches. But the answer is acupuncture will benefit for those people. Now go back to your field, rehabilitation and innovative pain management. Can you show us an example of the more innovative treatment for different type of headaches, let's say cervical organic problems that cause headaches? And, I know you have a lot of experience in this.
Yeah, I would like to show a lot of the stuff, because at the end of the day, I am a more interventional pain physician.
Yes,
I do minimally invasive procedures, which are usually much more effective in terms of how much they help and how little we need to repeat doing them for our patients than just taking medicines alone. So I have a couple slides that can showcase kind of like the different types of headaches and what are the more advanced kind of procedures that we do to help these. So I know, hold on. Okay, I know we already talked a little bit about, the Botox injections that can help with migraine headaches. This is something that I do relatively often. It's effective for patients. The only issue with this treatment is they do need to come back every 3 months when the Botox runs out. Just like facial Botox, when the Botox runs out of its treatment, you do need to come back to repeat the treatment. There
For,
are other...
for this is 3 months, every 3 months?
Every 3 months, every 12 weeks. Yes, that's for Botox therapy.
So it's about 150 units minimum.
It's actually 155 units is they did the preempt protocol. So the protocol that they did the blinded studies on showed that the Botox therapy helped. It's 155 units. For patients who are worried about the huge, 155 units is not a small amount of money if you buy it cash, but most major insurances do cover Botox therapy for migraines if you have shown to have failed the real conventional kind of medication management.
Mm-hmm. Thank you. But this is very useful, this one. Thank you so much.
Right. I mean, you can talk to your physician about it. I mean, most insurances do cover, Medicare covers it for sure. You just have to show in the United States, at least, that you failed 2 different classes of prescription medications for chronic headaches.
Yes.
Mm-hmm. Other injections are a little bit different. This is what we call a sphenopalatine ganglion block. So what is a ganglion? A ganglion is kind of like a cluster of nerve cells. A lot of times our fight and flight responses kind of run through these ganglions. A lot of times these pain syndromes are mitigated through this as well. So an SPG block is basically, you can do it a couple of ways. You can do it with a needle that runs through your cheek here under X-ray guidance. But the way I learned how to do it is just this special kind of device. I mean, you can make your own with a long Q-tip and a bunch of numbing medicine, but it basically goes all the way to the back of your nose and you drip numbing medicine to kind of stun the nerves in this ganglion. And what that does, it stops kind of these headaches, which are often cascading. The headache causes the headache to become worse and worse and worse. And it's very debilitating for patients. Sometimes they can't eat, they can't sleep, and they just have these disorders. This will temporarily kind of break that pain cycle and allows the nerves to kind of reset back to a base level. This is one of the things that I've done in the past. I don't do these much anymore because my practice is more of a spine practice. I do see some migraine headaches that I do Botox on, but when I was back in training, this is something that we used to do. Mm-hmm. There are other types of headaches, right? This is a procedure of something called a Gaussian ganglion block. So patients may have heard of something called a trigeminal nerve. It's a nerve that comes out from this area and it kind of goes in your face and provides sensation here. So patients may have heard of something called shingles. So sometimes patients have these shingle pains and they start having these pains in the nerves, or sometimes they just have trigeminal neuralgia or pain of the trigeminal nerve. That's a facial pain, which is a very devastating headache. Sometimes patients, can commit suicide because the headaches are so painful and debilitating in their life. Yes. So this is a procedure called a Gaussian ganglion block. What that is, the Gaussian ganglion is, again, it's kind of like where the nerve comes out in that, these area. You can put a needle, kind of goes in through the face here, and you target that foramen where the nerve comes out from, and you inject a local anesthetic to temporarily block the pain from that nerve. And that can give patients with this trigeminal neuralgia some relief. You can also do certain things like radio frequency, where this probe is connected to a radio frequency machine, and you can give an alternating current to cause kind of stunning of the nerve through this kind of electricity. And that's very helpful for some patients with this disease. People with trigeminal neuralgia, it's so painful, they're willing to try out these very invasive looking procedures. And some people also, they get like a surgical decompression. I know one of the neurosurgeons at UCI was one of the more prominent ones who would do kind of like a surgical decompression of the trigeminal nerve to help patients with this disease. I'd like to keep going. This is something called an occipital nerve block. I do these very often. Occipital headaches are headaches that people get from the occipital nerve, which is a nerve that runs from the back of the neck, kind of goes to the top of the head. Oftentimes, patients get this after a whiplash injury, a car accident, when their head goes back and forth, and it irritates these nerves that come from the base of the spine. So it's a very simple procedure. I mean, I guess simple once you're trained in it. You just kind of inject these nerves on the top of your head. with a mixture of numbing medication and steroid, and it can really help with patients' pain.
Mm-hmm.
This is a type of procedure called cervical ablation therapy, or a facet ablation therapy for patients with headaches that are caused from the neck. Now, in the slide before, I showed you these nerves that run to the head, but if you look closely, the nerves start from the base of the skull where the spine is. So in these different targets, the TON, the C3, C4, and C5, these nerves innervate, with the facet joints innervate these that can cause what we call a cervicogenic headache, or a headache caused by arthritis and degeneration in the spine. So in patients with these kind of headaches, what we do is we do, a couple nerve blocks to make sure that this will help them. And again, we'll put needles through the spine in the back using X-ray guidance into those spots, and we can do radio frequency or burning of the nerve so we can stop their pain signals going to their head. It's a very, very effective pain treatment in patients with these kind of neck pain plus headaches. I think finally I have neuromodulation, which is a little bit of my favorite interest. So neuromodulation is basically using medical device with electricity and technology to help with people's pain. So this is a neuromodulation of an occipital nerve stimulator. So basically the nerves go across where the wire with the electrodes goes across where the nerves are for patients' headaches, and they're actually in your skin. So you take a needle and you kind of bury the wire to go across the nerves inside, and the wire gets looped, and there's a little bit of a battery or a generator that gets implanted somewhere in your body. Nowadays, we have newer technologies where you just have to put the wire on, and the battery can be external, can be, you don't have to have a battery implanted in your body. It can be all external. But these are kind of, these newer procedures that help patients who have really failed all the other headache type therapies.
Yeah. Wow, it's amazing. Now we know, right? When you see, I went for pain management training also, but 35 years ago, you will not see this kind of a procedure. Technology has advanced, the training has advanced. He spent almost, what was it, like 18 months or 2 years in pain management training, right, Dr. Darryll?
It was 4 years of residency training, and then it's 1 year of fellowship training.
Fellowships, yes. So, but his fellowship training is more than just block and prolo. This is what he call it an interventional pain management. So minimal invasive procedure. So it's not like, so this is to avoid a bigger procedure, which is done by like a neurosurgeon or orthopedic surgeon in his case, because he's concentrating in a spine area. Am I correct?
Yeah, I mean, we do work very, very closely with a lot of our surgeons.
Yes.
But a lot of times, with the surgery, with the changes in the anatomy and you increase risk with the surgical procedure, the anesthetics and all that stuff. So a lot of times patients would like to try some minimally invasive procedures first. And nowadays with the advancements in what we have, it's a lot of times we can avoid surgery if possible.
Thank you. So talking about let's just move on, and we are almost done here. I'm sorry to keep you more than 30 minutes, but talking about rehabilitation, some headaches creates a problem in driving, working effectively, like you had already mentioned it. And it's really cutting the productivity, and often the patient has to stay home, especially when it is vertigo, let's say, and migraine. Can people with these severe headaches return to their normal function again?
Yeah, of course. That's always the goal of someone in pain management or even rehab. You want to return the patient to their baseline goals of quality of life, of their activities of daily living, of living independently. So whenever you do a treatment, you want to treat the symptoms based on what their pain generator is. So find an accurate diagnosis, and then you work with the patient together to set goals and see what they can do. So in terms of most of my patients who do suffer from migraines, they are working, they're fully functional, but they do require usage of maybe some more advanced therapies such as the Botox injections or the neck cervical radiofrequency to function effectively. The other thing is during the work environment, I think it's important to do some work modification activities. So if you're using the computer screen a lot, you want to adjust the computer screen into having good ergonomics. And I think that's important, that a lot of us don't think that our work setting, our ergonomics is really important, that can help reduce the incidence of any types of chronic pain for us.
Wow, we have to do just this kind of conversation more often. Now I know where to send my chronic migraine patient. Are those neuromodulation therapy covered by insurance in general in United States?
So that's a difficult question to answer. I mean, a lot of the neuromodulation therapy for example, for stuff in the spine, yes, they are covered. A lot of the stuff that are done for more of the peripheral nerves, a lot of the insurances deems it experimental. I mean, we do have some really nice data that comes out from Europe and Australia, and a lot of the big academic centers will try these because they are able to absorb the cost for this. But I mean, at the end of the day, I think unless their headaches are so severe that everything else has failed, I rarely, would recommend for someone to get a neuromodulate. You still have to implant this device in their head, right? So I would definitely encourage patients to try other therapies, be it Botox or nerve blocks or even medications before we go into something that's neuromodulation for headache treatment specifically.
Thank you so much for that information. And I would like you to do a take-home message if you have any before I close this event.
Yeah, so I just want everyone not to be afraid of your headaches. We do have the appropriate medications and treatments now. It is very difficult. There are new medications coming out all the time to to treat different receptors for headaches. So if you've tried medications in the past and it hasn't helped, there are new medications out on the market that can help with that. But and keep an eye out if you do have these sudden headaches that came out of nowhere and you notice certain other things like weight loss and weakness. I think it's important to talk to your doctor to make sure that it's not anything else that's more severe.
Thank you so much. And thank you for spending time with us in these headache topics. And we might have headache part 2, headache part 3, depends on the request. And for everyone who listened, please subscribe, like this video, and share with others. I'm Dr. Maria Sulindro, specializing in integrative anti-aging medicine in Pasadena, California. Every Thursday, we have live YouTube, and then we are on Facebook with the same address, Dr. Maria Aesthetic and Anti-Aging, and also in Instagram with the address of Ask Dr. Maria, ASK Dr. Maria. Thank you, Dr. Darryll.
Thank you very much.
Okay.